So coming back to our patient, this was a 64-year-old man who presented with GE junction tumor and radiographic evidence and biopsy-proven evidence of metastatic disease to the liver. We now have all of the biomarker testing back, and his tumor, as expected, is HER2 negative. And what's interesting is the tumor was found to have PD-L1 overexpression, but at low levels. CPS is 5. So it's intermediate PD-L1 overexpression. And the question is, what is the possibility now and later for this patient? What is the long-term vision for targeted therapies in this space? Well, there's been a lot of developments for first-line immune checkpoint blockade therapy. Checkmate 649 led to the approval of FOLFOX plus nivolumab globally in many countries in first-line setting. We know that patients with PD-L1 high overexpressing tumors benefit the most. And for patients with intermediate tumors, such as this patient, which is CPS 5, the benefit is there, but perhaps, and even the NCCN guidelines recommend use of therapy. But we know that for CPS less than 5 or CPS, equivocal PD-L1 testing, the benefit may not be as great. So for now, the plan is to continue to offer FOLFOX nivolumab, and that's what many different regulatory bodies recommended, although that's considered for CPS low or negative tumors level 2B recommendation based on the NCCN guidelines. But what is the future? And the future and the plan is for us to have more options for patients in first-line settings. So then you can decide based on biomarker testing as to what to offer. The treatment options that are available, hopefully in the near future, would be targeting FGFR2b antibodies with bemarituzumab in combination with chemotherapy that showed promising data in phase 2. The next wave of some of these trials involve capitalizing on the synergy that we saw in KEYNOTE-811 with HER2 plus PD-1 targeted agents. Here to use dual anti-FGFR2b and anti-PD-1 inhibition in biomarker selected. Certainly Claudin 18.2 hopefully will be entering the standard practice for immunohistochemistry testing in first line. So for our patient, currently PD-L1 testing and targeting PD-L1 is the preferred approach. But the emerging data and the long-term vision for our patient population is to use more of these biomarker selected targeted agents in first line. And after they progress on first-line therapy, the subsequent line treatments, that's where a lot of our efforts are placed in discussing and capitalizing on biomarker testing in second line. Currently, the standard is to receive paclitaxel plus ramucirumab in second line, and there's going to be much more development in that space in the near future.